Great. السلام عليكم. Good afternoon everyone. الله يتقبل منا الصيام والقيام وإن شاء الله يا رب تكونوا you're studying well. So today I'm not gonna make it so long. Inshallah it's gonna be short. I'll be doing pathology practice questions. The way I'm gonna do it is that I'll put the questions and then the answer. Then I'll explain the whole concept and then I'll go back and explain why the answer why it's the right choice. Okay. So, yeah, let's get started. I try to put questions from both pre and post mid lectures. Please, whenever you have any question, just unmute and ask. تمام. So let's get started. Bismillah. Um, I'm gonna read. A 55-year-old man with atrial fibrillation is brought to the emergency department by his wife 6 hours after the acute onset of right arm weakness and slurred speech. An MRI of the brain shows a thrombus in the left middle cerebral artery. 12 hours later, the patient dies. Which of the following histopathologic changes are most likely to be seen on a biopsy specimen from the affected brain tissue? So if you want to answer by unmuting and answering, feel free to do this, or if you want to just type in the chat, it's fine. And if you don't want to answer, it's fine, I can answer it. Go ahead and answer it. So let's just wait for a few seconds. Okay. I'll go ahead and answer it. So the answer here is D. It's eosinophilic neuronal cytoplasm with pyknotic nuclei. Now I'll move on to the second question and then I'm going to explain the answer. So question 2 is an 87-year-old woman is admitted to the ICU after a neighbor found her lying on the floor at her home. Despite appropriate therapy, the patient dies after 10 days. Gross examination of the brain at autopsy shows new vascularization and liquefactive necrosis without cavitation in the distribution of the left middle cerebral artery. Histopathologic examination of a brain tissue sample from the left temporal lobe shows proliferation of neural cells that stain positive for GFAP. Based on these findings, what else might be seen in the histological examination? So, based on this scenario, what do you think the answer might be? Yes, exactly, Sanya. It's reactive gliosis. So I'm just gonna go ahead and explain the concept of ischemic changes. So in both of the scenarios, we had patients that had ischemic ischemia to their brains. So what are the changes that could happen in case of ischemia? Now we all know that in case of ischemia, there will be a hypoperfusion state, so decrease in the perfusion of the neurons or the brain cells. As a result of decrease in perfusion, this would result in ischemic changes. And as you guys might remember from POD, one of the ischemic changes is basically cell necrosis. What happens in cell necrosis is that the cytoplasm becomes eosinophilic and the nuclei are going to be shrunken down. So that's why they are called pyknotic nuclei. So now we're going to be dividing the histopathologic changes based on time, so hours or days. The most recent thing and then the immediate thing that happens after an injury or an insult to the brain, an ischemia to the brain, is basically the cellular necrosis, which is characterized by eosinophilic cytoplasm and pyknotic nuclei. This happens within 24 hours. After 24 hours of cellular necrosis, now what's going to happen is that there will be inflammation. And what are the fastest cells that could come in inflammation? They're the neutrophils. So whenever someone asks you what happens between 1 to 3 days after ischemia, you will find neutrophils and necrosis, okay? Now, after the neutrophils, now we have cellular debris, we have a lot of dead cells. Now, what is the cell that's gonna come and remove all of this? It's basically the macrophage. What are the macrophages of the CNS called? They are called the microglia. Okay, so the microglia are gonna come within 3 to 5 days and clear all of that cellular debris. They will result in the formation of something called microglial nodules. Let me just explain it here. Now, we said that the first thing we have the red neurons, then the neutrophils, and then here we have the microglial nodules. So here we have the microglial cells that came and forming nodules in order to remove the cellular debris. Following the microglial nodules, we have the astrocytes. Astrocytes are the cells that are responsible for repairing whatever damage that's going to happen in the CNS. So these reactive astrocytes are characterized by their peripheral nuclei, as you can see here, and their clear cytoplasm. So they're gonna come, and what will they do is that they will result in the formation of a process called reactive gliosis. What does reactive gliosis mean is that they are going to try to repair to repair the damaged tissue by forming some of the glial scars. They will be later on be called glial scars. So this is basically what reactive astrocytes are going to do within 1 to 2 weeks. Now, also within 1 to 2 weeks, what happens is that there will be the formation of Rosenthal fibers, which are happening as a result of these reactive astrocytes as well. And these Rosenthal fibers are characterized by their GFAP positive staining. Here we can see these eosinophilic things that are over here, pinkish things over here. These are the Rosenthal fibers. Then after the reactive gliosis has been formed, we're reaching about 2 weeks, 3 weeks, and 4 weeks. What will happen in 3, 4 weeks? It's basically this glial scar will be formed. So we have the red neurons, which they are basically the pycnotic cells with their eosinophilic cytoplasm. Sorry, pycnotic nuclei with their eosinophilic cytoplasm. And then we have the microglial nodules within 3 to 5 days. Then we have reactive astrocytes. Rosenthal fibers are going to form within the reactive astrocytes phase, glials, and at the end, glial scars. Leave this till the end. I'll talk about it later. So now let's go back to our questions. For the first question, we have a patient who came 6 hours after the acute onset of right arm weakness. Then 12 hours, the patient died. So now we're in the period of 12 hours. What things might be happening in this 12 hour? It's basically the cellular necrosis and the formation of red neurons, which is basically why it is the eosinophilic neuronal cytoplasm with the pycnotic nuclei. The rest, we have neutrophilic, it's 1 to 3 days. Reactive gliosis, 1 to 2 weeks. Glial scarring, it's after 2 weeks. Microglial infiltration, it's basically 3 to 5 days. And normal, it's of course not the correct answer. Now, for question 2, here we have a patient who died after 10 days. So this patient had ischemia. However, this patient died after 10 days. And they are saying here that there is basically a proliferation of neural cells that are staining positive for GFAP. These are basically characteristic of the astrocytes. And what are the cells that are going to be found between 1 and 2 weeks, which is basically 10 days, are the astrocytes, which would lead to the formation of reactive gliosis. Everything is clear about this? Yes, okay. So now let's move on to question 3. A 28-year-old woman states that 3 years ago she experienced paresthesias of her left arm and had difficulty walking, but these problems resolved. During the past year, she developed difficulty seeing from her left eye. 6 months ago, she had difficulty writing with her right hand. On physical examination, there is decreased visual acuity on the left, no papilledema, and no retinal lesions. There is decreased motor strength and decreased sensation in the right hand and forearm. MRI of the brain shows focal areas of increased signal intensity in the periventricular white matter and in the left optic nerve. Lumbar puncture is performed. What would you see on CSF analysis? C? Okay, so Sania, would you like to tell me why would it be C? Or at least just give me the name of the diagnosis. Exactly, it's because it's MS. So here we have the answer is C. Now, I'll move on to the next question. So, question 4. A 28-year-old woman comes to the physician because of increasingly frequent episodes of double vision for 2 days. She was seen in the emergency department for an episode of imbalance and decreased sensation in her right arm 3 months ago. Examination shows impaired adduction of the right eye with left lateral gaze, but normal convergence of both eyes. Deep tendon reflexes are +4 in all extremities. The Romberg test is positive. An MRI of the brain shows hyperintense oval plaques in the periventricular region, and the plaque in the midbrain on T2 weighted images. Which of the following cells are primarily damaged in this disease? What do you think? B. MS again, exactly. So here we have basically the disease here is basically multiple sclerosis. Now, what is multiple sclerosis? Multiple sclerosis is a demyelinating disease that happens as a result of an autoimmune inflammation that is characterized by lymphocytes that are targeting the cells that are responsible for the myelination in the central nervous system, which they are the oligodendrocytes. So lymphocytes attacking oligodendrocytes. And this disease is more commonly found in females. And sometimes they also mention that these patients they have vitamin D deficiency. The cause is not known, but they found an association between female patients with vitamin D deficiency and multiple sclerosis. It's important to know the genes because sometimes they like to ask about genes, and the most important gene impaired in multiple sclerosis is basically HLA-DRB1. It's a disease that's characterized by relapsing and remitting. Now, what do we mean by relapsing and remitting? And it's important to note this thing. Why? Because relapsing and remitting means that the symptoms come and go. So, for example, 6 months ago, she experienced visual changes, and then they are gone. And then 4 months later, she experienced sensory damage, for example, or motor impairment, which is, for example, urinary incontinence. So this is what's meant by relapsing and remitting. Symptoms are coming and going. They are not continuously there, unless it's basically severe disease and the disease has severely progressed. So let's talk about the clinical features of multiple sclerosis. Now, since it's targeting the oligodendrocytes, which they are the myelinating cells of the central nervous system. So various things in the central nervous system might be affected. For example, the cerebellum might be affected, which would result in ataxia. We would also have intention tremors. Sometimes, for example, one of the most important things that could be impaired in this disease is basically the optic nerve, which would result in what's called optic neuritis. They might refer to it as visual changes, eye pain, sometimes diplopia or nystagmus, and internuclear ophthalmoplegia. Do you guys know about this or no? Because if they didn't teach it to you, I'm not going to go into the details of it. But it's a common finding in multiple sclerosis. Sania and Mariam, did you guys take it? Okay, let me just explain it. Yes, but okay, so let me just explain it briefly. What happens in intranuclear ophthalmoplegia is that whenever you want to take a look at a point, for example, I'm gonna look at this point over here. So my right eye is going to abduct in order to look at my finger over there, but my left eye is going to adduct. Now, what would result in my left eye adduction in order to look into my finger? It's basically the what's called medial longitudinal fasciculus. Okay, so I just explained it. That's fine. It's medial longitudinal fasciculus. This is basically what result in the opposite eye to look at a point on the opposite side. So this is basically impaired in multiple sclerosis, which is called intranuclear ophthalmoplegia. Now, other things that might be impaired, basically sensory sensations. So you might find some sensory problems, for example, paresthesias or tingling. And lastly, some of the motor impairments. For example, there might be some urinary continence, which is basically a very common finding in multiple sclerosis. They will tell you, for example, they might find some spots of urine, and which is basically not intentional, and things like these. And let's talk about the diagnosis. So whenever they do a biopsy or an autopsy, they will find the perivascular lymphocytic cuffs. It's basically characteristic of multiple sclerosis. What is it characterized by? It's basically the perivascular lymphocytic. Here are the lymphocytes, which they are perivascular lymphocytic cuffs surrounding this cuff, which is this area. One more thing that could be found is basically the periventricular plaques, which is basically like it's a pathognomonic for the multiple sclerosis. It's very important in most of multiple sclerosis questions. They will just tell you MRI showed periventricular plaques. What does this mean is that here we can find the plaques that are basically periventricular that are next to the ventricles. And one last thing about the diagnosis, they will tell you they did CSF analysis and they saw a very important thing in while doing the CSF analysis, which is basically the oligoclonal IgG bands, which is happening as a result of the autoimmune inflammation that's characterized by lymphocytes as well as immunoglobulins like IgG immunoglobulin forming oligoclonal IgG bands. Now, let's go back to our question. Let's go back to our questions. So here we had a patient that had paresthesias. First, she's a female, had paresthesias and had difficulty walking, but these problems resolved. So this is the relapsing and remitting. During the past, she developed difficulty seeing from her left eye. 6 months ago, she had difficulty writing with her right hand. So the symptoms are basically from the right to the left, from the right, from left to the right, coming and going, different symptoms. However, they are both under the same umbrella, which is the multiple sclerosis due to the impairment of myelination. Lastly, here we have MRI showed periventricular white matter lesions in the left optic nerve. So, and they did the CSF analysis, and what do they expect to find? It's basically oligoclonal bands. Just to let you know about the other answers, xanthochromia, it's something that's seen in subarachnoid hemorrhage. Adenomyocytological dissociation, it's basically seen in Guillain-Barré syndrome. And malignant cells, it's basically, we're going to talk about CNS tumors later on, but this is not a case scenario of a tumor. This is for question 3. For question 4, here we have the same kind of question stem, which is basically the double vision for 2 days, episodes of imbalance, decreased sensation 3 months ago. Then they said the MRI showed hyperintense oval plaques in the periventricular region. So which of the following cells are primarily damaged in this disease? Now, multiple sclerosis is a disease of central nervous system, which is why the answer is B, not D. D Schwann cells are also responsible for myelination, but for peripheral nervous system. For central nervous system, we have oligodendrocytes. So the take-home message from multiple sclerosis, know the gene, know the things and keep them in mind, which is basically female, vitamin D deficiency, relapsing and remitting, all of these things, they could put it in the question for you like to know more about the disease in order to be able to answer it. So here we have the clinical features as well. Periventricular, just focus on periventricular. Whenever you say periventricular, think about multiple sclerosis. And also we have the perivascular lymphocytic cuffs, and lastly, oligoclonal IgG bands. Now, just one thing I want to explain, I saw it in the lecture, which is basically the difference between demyelinating and dysmyelinating. So demyelinating diseases are diseases that are basically, there is something that's impairing the myelin sheath, okay? Something impairing the myelin and damaging the myelin sheath. While in dysmyelinating disease, it's basically the myelin sheath itself, it's impaired. How? For example, mutations or any disease that could result in deformation or an abnormality of the myelin sheath. So this is the difference between demyelinating and dysmyelinating in brief. Any questions about MS? Here. So let's move on to this question. A 68-year-old woman complains of difficulty getting out of a chair. On examination, the patient shows reduced facial expression, arresting tremor, cogwheel rigidity, and bradykinesia, which is slowness of voluntary movements. The patient dies of a congestive heart failure 10 years later. MashaAllah, okay. No need to read the whole question. So the answer here is E, correct? It's alpha-synuclein. Let's move on to question 6. A 60-year-old man with a history of smoking and chronic bronchitis complains of difficulty walking. On examination, the patient appears stiff and stooped, shows an expression of expressionless face, and speaks in a monotonous voice. A tremor of his fingers is apparent but ceases when he tries to reach for something. The patient dies 3 years later, and the answer is exactly. The answer is D. Reduced levels of dopamine. So, what's the disease here? Parkinson's. Exactly correct. It's Parkinson's disease. Type. Anyone wants to like kind of explain and just tell us about why why the answer here is alpha-synuclein, or should I go ahead and explain it?
Okay, so by eliminating the choices,
Mhm.
or like by identifying what's going on, they have resting tremor and the reduced facial expression, which are characteristic of Parkinson's, as well as cogwheel rigidity and bradykinesia. So when we look at the choices, beta amyloid and the tau proteins are related to Alzheimer's disease,
Mhm.
and B is a Huntington protein, which is not seen in the picture.
Mhm.
I don't know what C is, but so by eliminating C, we can conclude that E is
Yeah,
the answer.
that's smart. Yes, C is basically related to prion disease, which is CJD, if you guys know it. You maybe saw it in mall once. So just forget about C. So exactly, that's the correct explanation. Now let me just go ahead and explain quickly about Parkinson's disease. Parkinson's disease is basically a neurodegenerative disease that's characterized by loss of dopaminergic neurons in the substantia nigra. So the dopaminergic neurons are basically the ones that are resulting for its colorful brownish appearance, which is seen here. This is basically a normal substantia nigra. And here, basically, what happens is that because of the loss of the dopaminergic neurons, there will be depigmentation of substantia nigra. So this is basically important to know about Parkinson's disease. So because of the loss of the dopaminergic neurons, you guys should know the basal ganglia and its direct and indirect pathways, which are they are very confusing, unfortunately. So what happens is because of the loss of the dopaminergic neurons, they will have some symptoms of decreased activity, which is basically when we, for example, bradykinesias, when they have here stooped postures, rigidity, and different type of symptoms. However, there is basically a mnemonic, which is trap, tremor. They will have pill rolling tremor. They will have cogwheel rigidity, bradykinesias or akinesias with shuffling gait, and postural instability, which is basically tendency, they might have tendency to fall. So what's the pathogenesis and what might be happening is that alpha-synuclein is a protein that's basically important in synaptic transmission. So whenever, and every protein, what's like the fate of every protein, they'll be broken down later on. So whenever we have a defect in the breaking down these proteins, which is basically as a result of defect in lysosomal degradation, these proteins are going to accumulate and accumulate in a form of what's called Lewy bodies. So Lewy bodies basically it consists of alpha-synuclein. Here I collected different pictures from different books for Lewy bodies. Guys, just make sure to memorize every single histopathology picture because they're very important and sometimes they get a question. They put a picture and they expect you to answer based on the picture itself, not the question. Okay, so please make sure to know each question, what does it, each picture, which disease it's related to. So here are three different pictures for Lewy bodies showing alpha-synuclein, which they are characteristic for Parkinson's disease. So here you explained this correct. Then here it's basically, as we said here, because of the depigmentation of substantia nigra, we have we're suspecting Parkinson's disease, and here the symptoms basically are like directing us more towards Parkinson's disease, which is happening as a result of reduced levels of dopamine. Any questions about Parkinson's? Cogwheel rigidity. Sure, I can. One second, let me just go to the slide. Here we have cogwheel rigidity. So I don't remember exactly what was the cogwheel rigidity movement itself, but as far as I remember, it's happening as a result of, so whenever basically there is in the basal ganglia pathway, we have direct and indirect pathways. So whenever there is a loss of dopaminergic neurons, because of this loss in the basal ganglia, like the direct and indirect pathways are going to be disrupted. So the patient sometimes might be able to do some of the things like in a form of spasticity, while other things are going to be decreased. There will be decrease in their activity because of the loss of dopamine. because you guys know that in the basal ganglia, there is basically the inhibitory and excitatory pathways. So in Parkinson's disease, sometimes these things might be happening and intercalating together at the same time. So sometimes they have rigidity, while on the other hand, they might have bradykinesias and postural instability. Did you get the explanation? Sure. If you still don't understand it, no problem. We can like talk about it at the end, or if you can just text me or email me, and I can search it up more and get back to you. Tamam. So if everything is clear about Parkinson's, we can move on to the second question. So here we have question 7. A 47-year-old woman from Venezuela has had difficulty performing activities of daily living for the past year. She's emotionally labile and often cries. She is disturbed and depressed by these developments because her mother and brother died 5 years after experiencing the same symptoms. On physical examination, she has coriform movements of her extremities. Cranial nerves are intact. She has no motor weakness and no sensory deficits. Her memory remains intact. Which of the following changes most likely be seen in the brain of this patient? So C. Why is it C? If it's like the right answer, why would it be C?
The degeneration of the striatum, which is seen in Huntington's disease.
Exactly. So it's mashallah, it's good that you knew that it's basically Huntington disease. Here we have different things in the question. I'll talk about them in details when I explain about it. But we have different things in the question that will basically lead us more toward the Huntington's disease. So question 8. I'm not gonna read. I think it's fine. You can just read it quickly, like faster than me even. So, B. Okay. Mashallah, are the questions that easy, or you guys are mashallah so good? I think neuropatho is nice. It's simple. It's straightforward. Exactly, it's B. So it's expansion of trinucleotide repeat. Um, your explanation, Sania? If you have an explanation, feel free to unmute and just say it. If you don't, I can just go ahead and explain it. Okay, I'll go ahead. Think. So basically, this is Huntington's disease. What happens in Huntington disease is that there will be loss of GABAergic neurons, which is, as you correctly mentioned, in the striatum. Just keep it in your mind. Striatum is composed of the caudate and the putamen nuclei. Here you can see the caudate and the putamen nuclei. So there will be loss of GABAergic neurons in the striatum. Why is this loss happening? It's happening because of an accumulation of Huntington protein. Now, why does this protein gets accumulated? It's because of we have a mutation, which is trinucleotide, which is like a CAG trinucleotide mutation, resulting in impairment of this protein degradation and removal. Thus, this protein, Huntington, will accumulate and result in the disruption of these cells, which they are the caudate and the putamen, which they're called as the known as the striatum. So as a result of loss of GABAergic neurons, there will be like less inhibition, which means that there will be more of movements, which is basically characterized by chorea, athetosis, and sometimes actually these patients might have aggression and abnormal behavior. So sometimes in some of the questions, they might not focus on the chorea movements. However, they might focus on aggression and abnormal, unrespectful behavior, which is basically indicates Huntington disease. Now, one thing I want you guys to note and to keep it in the back of your head when answering some questions related to neurodegenerative diseases is to take a look at the age as well as family history. So here we have autosomal dominant. I'm not expecting you to remember what does it mean exactly, but what happens whenever a mutation is an autosomal dominant, it's basically easily transmitted from one generation to another generation. So In the question, we might find that they have positive family history. Their dad, their mother, their siblings, their grandparents, they actually had similar symptoms and they died because of these symptoms. So whenever you see an age of 30 to 50 with positive family history of someone died in the family or had similar symptoms, keep Huntington in the pool of the answers, okay? Um, And one more thing about Huntington disease, it's basically, as I told you guys, it's characterized by atrophy of the striatum. So sometimes they might get you some questions and a clinical scenario of Huntington disease and put an image of a brain like this for you. And I remember I got a question about this concept. So what do they say is that they will tell you, now point out which of the following might be affected. They will put on the substantia nigra, they will put on the internal capsule, they will put on the caudate. And of course, you're going to pick the caudate, تمام? So just make sure to know the anatomy and correlate it with the pathology. And now let's go back to our questions. Here we have, so let's see this patient. What did she have? So this is basically a 47-year-old woman, 30 to 50. Okay, 47. We can consider this. She's emotionally okay, and on physical exam. Okay, so here we have her mother and brother died 5 years after experiencing the same symptoms. So now we have the age, and now we have positive family history of similar symptoms. And then we had the coriform movements of her extremities. So which of the following changes might be expected? As you guys correctly mentioned, it's basically gliosis or scarring of the caudate and putamen nuclei. Sometimes you might see only caudate, sometimes you might see striatum and only striatum. Now, what's the pathogenesis and what happens in basically Huntington's disease? It's basically as a result of trinucleotide CAG repeat. And here basically we have the same thing, 35-year-old male. His mother and maternal grandfather had similar clinical symptoms. So this is basically highlighting that it might be Huntington disease, and you guys correctly mentioned that it's Huntington. Any questions about Huntington disease? Okay, clear. Is the pace fast or slow, or am I going good? What do you guys want me to slow down, or it's good? Perfect. Okay, alhamdulillah. Now let's move on to question 9. Tamam, bravo. Alzheimer's. Okay, so here basically the question is pointing towards Alzheimer's disease, and it's highlighting that it is hyperphosphorated tau protein as shown in this image. So question 10. MashaAllah, Sania, you mastered pathology. Yes, exactly. The answer is D. So the answer is extracellular accumulation of amyloid plaques, and both questions are about Alzheimer's disease. So let me just go ahead and explain why the answers are like this, and what's basically Alzheimer's disease and what happens in Alzheimer's. So guys, here I think you saw this in your slides. So I'm just gonna go ahead and try to explain it in the easiest way as much as I can. So here we have an amyloid precursor protein. This protein is an amyloid precursor protein. It's normally found in the cells, in the neurons, in the cell membrane of the neuron. So here is the cell membrane, and this is the protein. Tamam? Now, as we mentioned earlier, every protein will be broken down later on. And what helps in breaking down this protein? Normally, it's the alpha secretase and gamma secretase. They will cleave this protein from a site that would allow it to be soluble. This basically fragment here, it's going to be soluble, which allows it to be like removed by the body normally, and no problems are going to happen. Now, what happens in the case of whenever we have another enzyme that's coming to join us in the party and cleave this enzyme, cleave this protein? It's basically the beta secretase. So when beta secretase comes, it cleaves this part, and then we have normal cleavage that's happening by the gamma. This would result in three fragments: this one, which is soluble, and this one. Unfortunately, this one, it's not soluble. However, when it's connected to this part, it's going to be soluble. Now, because of the beta secretase, it's not connected to this part, and that's why it's basically insoluble. This part is called the amyloid beta peptide, or amyloid beta protein. Tamam? This is basically the amyloid beta. Now, what will happen to this amyloid beta? Now, guys, focus now. Now we're talking about extracellular, and we're not intracellular yet. We're extracellular because this is the membrane. We're outside. So extracellularly, this amyloid beta monomer or peptide is basically, because there will be a lot and a lot and a lot, they will aggregate together. Because of their aggregation, they will go all the way and inhibit the synaptic transmission between at the synapse. So they will impair the synaptic transmission. Tamam? So this is the first thing that's going to happen. Extracellularly, we have the formation and the aggregation of amyloid beta, forming what's called amyloid beta plaques or senile plaques. Tamam? This is extracellularly. Now let's move on intracellularly and see what happens intracellularly. Intracellularly, we have also these amyloid beta monomers. Some of them, they tend to enter the neuron, enter the cell. And in the cytoplasm, what do we have? Normally we have microtubules, and these microtubules are responsible for the transportation. One of the important proteins of the microtubules is the tau protein. Now, when amyloid beta enter the cell, they will result in hyperphosphorylation of this tau protein. The exact mechanism is not known. However, it was shown that they will result in hyperphosphorylation of tau protein. Now, whenever tau protein is hyperphosphorylated, it will be removed from the microtubules, and they will impair the microtubules. Because whenever they are removed, they will basically tend to aggregate together, which would result in the formation of neurofibrillary tangles. So now we had two main things. The thing that's happening extracellularly, and the other thing, which is basically formation of senile amyloid beta plaques, and what's happening intracellularly, which is basically hyperphosphorylation of tau protein and the formation of neurofibrillary tangles. Keep those in mind, because now we're going to talk about it whenever basically we talk about pathology, because they have different pictures. Here we have basically the neurofibrillary tangles. As we said, it's basically found inside the cell. Memorize the picture of the neurofibrillary tangles very well, because like 100% they will get some exam questions. Inshallah, they don't get hard questions. Inshallah, it's gonna be easy. But like, just know the exact picture, because whenever you're gonna see the picture, khalas, by default you'll know the answer. Sometimes you don't even have to read the question itself. Tamam? So here's basically a picture showing amyloid plaques, and here is another one showing the neurofibrillary tangles. Focus when they say in the question extracellular or intracellular. Tamam? Intracellular, we have neurofibrillary tangles. Extracellular, we have the amyloid plaques. Now let's go back to our question. Now, one more thing I want to explain, which is basically the difference between sporadic and familial. This is something I saw it in your presentation. So let's just differentiate between them just quickly. In sporadic, it's basically what happens in most of the cases, which is basically what's seen in elderlies. It's happening most of the risk factors are related to age. However, it's basically we have sometimes some genes that are going to be impaired. Of these genes, we have the apolipoprotein E, specifically E4, because what would this result in? This would result basically in impairment of the normal removal of the beta amyloid, which would increase the risk of having beta amyloid plaques formation. So this is the first thing. apolipoprotein E4 is related to late onset Alzheimer's. Now, on the other hand, we have the early onset Alzheimer's. It's not very common, which is basically the familial, it's the same thing. And it's most likely to be seen in patients with Down syndrome. Why Down syndrome? Down syndrome, it's trisomy 21. So they have extra chromosome 21. On this extra chromosome, we have the APP gene as well. So now we have an extra APP gene. So now we have more APP genes, and this increases the risk of having beta amyloid plaques formation. Tamam? So this is basically how to differentiate between early onset, which is basically familial, and the late onset, which is happening as a result of age and apolipoprotein E4. Tamam? Let me just go back to the questions. Here we said that this is basically a scenario about a patient with Alzheimer's disease. As you guys know, Alzheimer's patients, they might have some cognitive dysfunction, some severe memory loss. So here we have, because of evaluation of impaired memory, word finding difficulties, she's no longer able to coordinate her tasks. These are like symptoms pointing us towards dementia and Alzheimer's disease. Also, the age is important. Here we have a 73-year-old age. Lastly, they put for us this picture, which is basically the neurofibrillary tangles happening as a result of the hyperphosphorylated tau. The second thing here is basically the same thing, the same symptoms: forgetfulness, trouble remembering names, increased amount of assistance with getting dressed, which is basically the basic things, and was diagnosed with Down syndrome during infancy. So this is basically like makes us think more about Alzheimer's disease. And deficit in short and long-term memory. These are all pointing toward Alzheimer's disease, which is extracellular accumulation of amyloid plaques. Now, important thing, guys, and this question, when I wanted to put this question, the answers that they put, one of the answers was extracellular amyloid beta protein. تمام? But I removed the answer because I don't want you guys to get confused. So just like memorize the picture and know that this picture is for neurofibrillary tangles, and the other one is basically for the senile amyloid beta plaques. تمام? Here we have some of the clinical features, and one of the important things about the diagnosis of Alzheimer's disease, whenever they do an MRI, sometimes they do find an important finding, which is a narrowing gyri and prominent sulci. Now, what do they mean by this is that the sulci are the ones that are in between, like this is normal and this is abnormal, okay? So the left one is normal. These are the sulci in between. The gyri are the like cerebral hemisphere here and here, here and here. Okay, so what's happening is that narrowing of the gyri. So gyri are going to be narrowed. This gyri narrowed here, narrowing, and widening of the sulci, which is basically the black area, the blackish area. It's basically widened. So this is a prominent finding in and Alzheimer's disease. And one more thing, sometimes they will tell you on MRI they found like sclerosis or fibrosing of the hippocampus or the medial temporal lobe. This makes us more think about Alzheimer's disease. Tamam? So two things: narrowed gyri, prominent sulci, and sclerosis of the medial temporal lobes or the hippocampi. Any questions about Alzheimer's? Clear. Let's move on to question 11. I'm sorry, guys, I put your question about genes, but because I saw that it was important in your slides, so bear with me. C. Okay. So yes, correct. The answer is C. Actually, when I first saw the question, I said that it's A, and then I was I was so shocked when it was C, because like I just know that ALS SOD1 mutation. That's what I know about ALS. But whenever I saw that in your slides, the doctor mentioned different genes, and one of the genes was C9 ORF72. And why the answer here is this gene? It's basically in the question it's mentioned that hexanucleotide repeat expansion of which of the following genes is the most common cause of familial ALS? So what I want you to know from this question is that just know the most common cause of familial ALS. It's basically hexanucleotide repeat expansion of this gene here. تمام. And know some of the other genes, which is like SOD1, which is an important gene for the ALS, I think. And I think you guys took this in anatomy. You most probably took this in anatomy, صح? Right? So just briefly talking about the anatomy, it's basically a disease of the upper motor neurons as well as the lower motor neurons. So you will find an intercalating symptoms between upper motor neuron lesions and lower motor neuron lesions, which is flaccid limb weakness, fasciculations. We might see some spastic limb weakness, some hyperreflexia, and different things. As I told you guys, that's why I know that it's SOD1 mutation. I never knew about the C9, but just memorize it. It was mentioned in your slides. And one more thing, know about ALS. It's basically most of the patients, if they die, it's going to be because of the respiratory failure. So they might get you a question, and the question is basically mentioning different symptoms of upper motor neuron and lower motor neuron signs. And then they tell you this patient unfortunately died. Which of the following might be the reason of this patient's death? So you'll know that it's a respiratory failure. It's very important to know this. تمام? If they mentioned it, just know it. If they didn't, just keep it in the back of your head. Now, question 12. Okay, so I want someone to explain why A.
I can.
Yeah, sure, go ahead.
So first of all, the appearance is cloudy, so that's specifically for bacteria. The opening pressure for bacterial meningitis would be from 200 to 300, so that's in the middle. Well, plus the low glucose is a sign for bacterial meningitis because, like glucose is taken up by bacteria, so this is why they end up with hypo. Elevated proteins as well. Oh, the pigments, because in other like in viral and other types of meningitis, it would end up with like lymphocytes and so on. So in this one, they're pigments.
Exactly, mashallah. That's the like the correct explanation for this question. You guys might have seen the lecture itself. Like I was confused because I didn't know what to add from the lecture because I remember we took the same lecture, and I immediately screenshotted the slide and sent it to my friends, which is this slide. And I told them, guys, I remember we got a question from this slide, but I can't remember what was the question exactly. And from what we remembered is that the question was something like this. So they got us a scenario, and then they put these things. For example, the opening pressure, they put the WBCs, proteins, and glucose. Unfortunately, they didn't put normal values, but maybe it was a mistake and the question was deleted. I'm not sure, but they have to put the normal values, so don't worry about this. But the reason I brought this question is that I want you to kind of differentiate between bacterial, viral, and fungal infections. تمام. And what's the important thing and the that makes us differentiate bacteria than others is basically the polymorphonuclear cells, as you correctly mentioned, Maryam, as well as the glucose. Glucose here is going to be reduced, and the proteins that are going to be elevated. Proteins most probably because of the lactic acidosis and the production from the bacteria itself, and the glucose because of the bacteria they feed on on glucose. Tamam. And it's basically, as you correctly mentioned here, it's leukocytosis, not lymphocytosis. So I don't want to like confuse you a lot about this table, but did you guys take in micro the cryptococcal infection and the tuberculous meningitis or not? Okay, it's good that you took them. It's good that you took them. So what I suggest from this table is that know that in bacterial meningitis, the opening pressure is going to be way elevated. Polymorphonuclear cells, glucose is going to be very low, reduced, and protein is going to be high. So they might get you the similar question to this, and they ask you what would be the next step and what would you do next. Now, what would you say is that they will put in the answer, for example, viral PCR, they will put acid-fast bacillus stain, they will put Indian ink cryptococcal antigen, and they will put gram stain. So you will go to gram and put gram stain because you know that it's bacterial meningitis. Now, the other thing is basically viral meningitis. Viral meningitis might not have an increase in opening pressure. It has lymphocytosis. Glucose most likely is going to be normal. Protein most likely normal, but sometimes it could be elevated. Tamam? For tuberculous meningitis, it's kind of the same as the bacterial, as you might notice here. There might be an increase in the opening pressure. Glucose is going to be reduced because it's a bacteria, and protein is going to be elevated. However, the important differentiating factor is the lymphocytosis. So keep an eye on the whether it's lymphocytosis or leukocytosis neutrophils. For cryptococcal meningitis, it's basically fungal. And fungal infections, now you might say, how can I differentiate between fungal and tuberculous? So sometimes you might not be able to differentiate in the question itself. However, they will give you like some hints, of course, in order to differentiate between both of them. Tamam? And then yeah, that's mainly the most important things to differentiate between the viral, bacterial, and fungal. Any question about this? Like the reason I'm talking about it is because I skipped all of this lecture and I didn't study the table, so that's why I got the question. I'm not sure if I got the question wrong or right, but I remember we got the question from this table, so make sure to know it. Tamam? Okay, let me just move on. Question 13. Here comes the fun part, CNS tumors. Take your time and think about it. Yeah, a few more seconds and I'll show you the answer. 1, 3, 2, 1. Yes, the answer is A. It's pleomorphic cells forming pseudopalisading. Like there are pseudopalisading nuclei around the central necrosis. This case is basically about glioblastoma multiforme. I'll go ahead and explain it like towards the end. Now let's move on to this question 14. And 5 more seconds. 5, 4, 3, 2, 1, and yes, the answer is C. It's medulloblastoma. Question 15. Read the scenario very well. Whenever you read the scenario, just let me know because there are pictures. I'm going to show it to you and you choose the answer. So read the scenario very well. And whenever you finish this, just write in the chat. Done reading. تمام. Let's wait for the rest. Maryam, W, N. Done. Yalla, we're left with W. Last 3 seconds. 3, 2. Okay, done. So let's move on to the answers. Are you guys sure that it's C? Think about it. GFAP positive, and the age is 13 years old boy. There are Rosenthal fibers. Oh, sorry, it's C. Yeah, correct. It's C. Why is it C? It's because of the patient is 13 years old. They said that there are Rosenthal fibers and it's GFAP positive, and the tumor is in the posterior fossa. So I'm gonna explain every type of tumor, and then I'll go back to the question and explain the question once again. So here we have the CNS tumors. Now, it's an important thing to differentiate between the children tumors as well as the adults tumors before actually studying each type of tumor. Now, other than differentiating between children and adults, to know what are the cells that are basically these tumors are arising from. So we have the astrocytes, we have the oligodendrocytes, we have the ependymal cells, we have the neurons and the meningeal cells. Tamam? Then we have children and adults. So from the astrocytes, we have two types of tumors, the GBM glioblastoma multiforme in adults, and we have the parocytic astrocytoma in children. Tamam? And both are GFAP positive because of astrocytes. Also, we have the oligodendrocytes, which they are the CNS myelinating cells. And the most important tumor is basically oligodendroglioma, which is basically an adult tumor. Tamam? Ependymal cells, it's basically ependymoma in children, which they are the cells lining the ventricles. So no, they are the cells lining the ventricles. So this basically gives us a hint where might be the location. Neurons, we have most importantly is basically the medulloblastoma, and the meningeal cells, basically meningioma. Tamam? In adults. So no, children, no, I want you guys to memorize them with me. Children, we have three, adults, we have three. The three in children are PEM, pilocytic astrocytoma, ependymoma, as well as medulloblastoma. Tamam? In adults, it's going to be glioblastoma multiforme, oligodendroglioma, and meningioma. Tamam? We're clear about this? Now let's move on to study each one of them like alone. So from each one of them, I'll just put a gross and like how to know it in a gross anatomy, and how to know it on biopsy. Tamam? And then there will be a mnemonic for you to be able to understand it. I actually personally hate mnemonics, so I just memorized them purely. But I tried to come up with mnemonics, and some mnemonics I got from Dirty Medicine and my friends. So here we go. Glioblastoma multiforme. Glioblastoma multiforme is one of the most important and malignant tumors that are happening in adults. Tamam? And what is it characterized by on MRI, or when you basically, if the patient unfortunately dies and you do an autopsy, what will you find is basically on gross anatomy or on an MRI is a lesion that's basically crossing the midline. So it's very important to know that it crosses the midline. This is basically a keyword in the question. So crosses midline, and it's basically butterfly shaped. So sometimes they might write crossing midline, or they will write butterfly shape. Tamam. This is about gross anatomy. Here we have histopathology. Now, what happens in this type of tumor is that there will be a central necrosis, and the central necrosis. Let me just put the pen. Yes. Oh, sorry. 1 second. Okay, so here we have the central necrosis over here. So this is central necrosis surrounded by pseudo palisading nuclei. What does it mean? What do palisading nuclei mean? Palisading means like lining, okay? Now here why is it pseudo? Because these cells are not actually lining this cavity here. They are not like known for lining this cavity here. No, there's just a necrosis, and these cells are surrounding this necrosis. So that's why they're called as a pseudo palisading. So pseudo lining nuclei. So these are here the cells and the nuclei that are lining the central necrosis. So it's basically central necrosis as well as pseudo palisading nuclei. A mnemonic to remember it is basically glioblastoma multiforme, P in blastoma for pseudopalisading nuclei, and M in multiforme for it crosses midline. تمام? So pseudopalisading nuclei and crossing midline. So this is about glioblastoma multiforme. Now let's move on to oligodendroglioma, the second tumor that happens in adults, which is basically a tumor of the oligodendrocytes. Now it is characterized by its focal hemorrhage and calcification. I honestly, like, I don't expect you to know that. I'm not sure if they do, but like, it's hard to remember that, okay, this is basically hemorrhage and calcification. It might be important, it might not, but the most important thing about oligodendroglioma is it's basically histopathology. Why it's histopathology? Because it's very characteristic of oligodendroglioma. What can we see in oligodendroglioma is what's known as fried egg appearance. Now, what is a fried egg appearance and why is it called like this? Because as you can see, guys, here we have, let's just focus on this. Here we have a kind of a fried egg. The whitish part here is basically the egg white, and the egg yolk is basically the nucleus here. So let's just take another one. This one, basically, the whitish part is the egg white, and then the nucleus is basically the egg yolk. That's why it's called fried egg appearance. And the mnemonic, which is basically from Dirty Medicine, it's very good mnemonic, and my friends told me about it as well. It's basically egg, dendroglioma. So egg for fried egg appearance. Tamam? So that's basically correlating oligodendroglioma, egg, fried egg appearance. Then we have meningioma. For meningioma, it's basically a tumor of the meningeal cells, basically arising from the meninges. Here we can see that this basically here is basically the meninges. Yeah, these are the meninges. And we have the tumor. Basically, this is basically the tumor here. It's basically arising from the meningeal cells and kind of compressing the cerebrum. Tamam? And it's characterized by its attachment to the meninges, which basically its tails. So here we have one tail, and here we have another tail attaching this whitish thing attaching to the meninges, and then they are compressing the cerebrum itself, forming like a kind of a ball. تمام? And of its important histopathological findings are two: whorled pattern and samoma bodies. So these are basically, whorled pattern is basically the thing that's like kind of doing a circle, like it's going like this, and also we have here like this. So by the time these whorled patterns are going basically to form like aggregate together and form the samoma bodies, as we can see here. Here, these are the samoma bodies. تمام? A mnemonic to remember meningioma is men have problems with PSA. PSA is the prostatic antigen. So men for meningioma have problems with W standing for world pattern, P and PSA standing for samoma bodies. تمام? Then we have the pilocytic astrocytoma. Now we finished the adult tumors. Now we'll move on to talk about the children tumors. We have pilocytic astrocytoma, which is basically a tumor arising from the astrocytes. تمام? It is characterized by, grossly, it's characterized by its cystic lesion with nodules. What do we mean by this is that here we have a cystic lesion. This is basically the cyst. And this is here the nodule. تمام? So they might bring you an MRI, hopefully not. If they bring an MRI, you will see a cyst, a whitish cyst, and an area of a nodule that's surrounding this cyst. Here, basically, gross anatomy, we can say a cyst with its nodule. And for histopathology, since it's an astrocyte, and do you guys remember astrocytes? They do the reactive gliosis and these kind of things. They also result in the formation of Rosenthal fibers. These Rosenthal fibers are eosinophilic, corkscrew fibers are like, this is basically how to explain them. What are the horizontal fibers? Here we can see one, here we can see another one, here we can see a third one. So these are characteristic for pilocytic astrocytoma, and they stain GFAP positive. It's important to note that they stain GFAP positive. What other adult tumor arising from astrocytes stains GFAP positive as well? It's glioblastoma multiforme. So we have glioblastoma multiforme, polycystic astrocytoma. Glioblastoma multiforme, its anatomy, and grossly it crosses the midline, while pilocytic, it's basically cystic lesion with nodule. For the histopathology, glioblastoma multiforme pseudopalisading around the central nucleus, central necrosis, sorry. And then in parocytic astrocytoma, we have the formation of Rosenthal fibers. You can also think about Rosenthal fibers. It's basically as a lollipop, a pinkish lollipop that children like, which is basically why pilocytic astrocytoma found in children. Here, the mnemonic is pilocytic astrocytoma. This is the mnemonic I came up with. You can see that I'm bad with mnemonics, but I tried my best. Here, it's instead of saying Paris, just replace the I with O, Paros. Or if you know the restaurant Paros, it's a Greece restaurant, so cafe, sorry. So just replace the I with O. Let's go with Paris. Paris, replace the I with O, it's Paros. So we have Pa for pilocytic astrocytoma, Ros for Rosenthal fibers. Actually, it's a good mnemonic. It's not that bad. So we're done with parasitic astrocytoma. Then we have medulloblastoma. So medulloblastoma is another tumor of that happens in children. It's characterized by it's basically its location is not that important because it could happen in the cerebellum, could happen in the fourth ventricle, could happen in the posterior fossa, could happen in the brainstem. So like children tumors, they are known to happen in these places, so it's not that important to know where exactly. But the most important thing about medulloblastoma is to know its histopathology. Its histopathology is characterized by small round blue cells. These round blue cells, 1, 2, 3, these are small round blue cells surrounding an area of what's called a neuropil. Tamam. This forms Homerite rosette. Rosette is basically, think about it as a rose, flower, or whatever. So here we have, like, let's take another circle. Here we have these blue cells surrounding this area in the middle, forming what's like a rose or a flower. So that's why they're associated with small round blue cells surrounding with Homerite rosette. Now, a mnemonic for medulloblastoma is basically this mnemonic is a mix between me and dirty medicine. It's blast a blue cell with a hammer. Replace hammer with Homer. So blast a blue cell with a Homer. Okay. So blast for medulloblastoma, a blue cell, which is small round blue cells, Homer, which is Homerite rosette. Tamam? Then after medulloblastoma, we have ependymoma, which is the last thing. Ependymoma is basically a tumor of the ependymal cells, which they are lining the ventricles. So where are we expecting them to be? Basically like around the ventricles. And most importantly and most commonly, they're going to be found lining the fourth ventricle. So they might, in the scenario, say that like a tumor is invading the fourth ventricle, causing hydrocephalus, and whatever. Tamam. For its histopathology, actually, it's hard. I don't know why it's like this, but it's perivascular pseudorosette. So it's pseudo rosette. Don't ask me why it's a pseudo rosette, not an actual rosette. I'm not sure why, but it's a perivascular. So here we can see that an area of the vascularization, this area of the vascularization, surrounded by an area of surrounded by cells, which is basically characterized by perivascular pseudo rosette. Which one has the normal and regular rosette? It's basically Homerite rosette, which is seen in medulloblastoma. In ependymoma, it's perivascular pseudo rosette. So here is a mnemonic from Dirty Medicine. It's ependymoma pseudorosette. So ependymoma, just replace the O with an A. So mama and pseudorosette. Pseudo is a false. Rosette is a flower. So someone or he gave his mom from mama, ependymoma, a pseudorosette, a false flower, because of like I don't know why, but like this is just the mnemonic. I think it's easier to memorize that it's perivascular pseudorosette than memorizing the mnemonic. So now let's go back to our questions. Okay, so sorry, one last thing I want to mention is that the locations. So it's important to know also the location of the tumors, the difference between adults and children. Most of children tumor happen below what's called the tentorium. So tentorium is dividing the area of the cerebellum and the structures around the cerebellum and the structures above it, which is the cerebrum. So if you guys noticed, most of the children tumors, they could happen in the posterior fossa, cerebellum, brainstem, fourth ventricles. They're all below the tentorium. Tamam? Just know this. Now let's go back to this question. Here we have a 49-year-old man. So this is an adult tumor. Adult tumors, we said that we have either glioblastoma multiforme, oligodendroglioma, and ependymoma. And meningioma. An MRI of the brain shows a mass that's basically crossing midline. خلاص, we saw cross midline. Like, I'm not gonna say 100%, but it's 99%. It could be glioblastoma multiforme. It's poorly demarcated, hemorrhage, necrosis, and it's basically as shown here. What's shown here is basically glioblastoma multiforme, which is characterized by glioblastoma multiforme, P for pseudopalisading. So pseudopalisading with central necrosis. Clear cells with clear cytoplasm and central round nuclei. Clear. I'm not sure which tumor is this, to be honest. Small blue cells arranged in rosettes. This is basically medulloblastoma. Nests of meningoepithelial cells. This is meningioma. تمام. Here we have, actually I think clear cytoplasm. This is oligodendroglioma. Oligodendroglioma. It's fried egg appearance. I just memorize it as fried egg appearance and that's it. So it's clear cytoplasm with central nucleus. Correct. Then we have question 14. It's here we have, it's a 40-year-old girl, so it's basically children. So this is pilocytic or medulloblastoma or ependymoma. Broad-based gait. This basically indicates that it's most likely happening in the cerebellum. Bilateral ocular disc swelling. This is just tells us that there is an increase in intracranial pressure. Okay, so forget about the question. You saw that it's 4, and then you saw the histopathology here. So this is basically showing us that there are blue cells surrounding an area of what's called as a neuropil, forming what's called as Homer-Wright rosette. So it's medulloblastoma. For question 13, we have a 13-year-old boy. So that's kind of still considered as children. And then we have well-demarcated cystic mass in the posterior fossa. So we have 13. We have a mass in the posterior fossa. So 13 mass posterior fossa, this is children tumor, okay? Cystic mass, if you guys remember, I said cystic with nodules, this is pilocytic astrocytoma. So now we're kind of know that it's pilocytic astrocytoma. To know, like for further confirmation, they said that identifies Rosenthal fibers, which they are GFAP positive. So this is astrocytic tumor. So now we have 13 posterior fossa. This is children. Cystic adds for pilocytic astrocytoma. GFAP positive, this is astrocytic, like a tumor of astrocyte, which is basically like خلاص, now we're at the pilocytic astrocytoma. Now here, how do we know which one is pilocytic astrocytoma? It's basically the one that shows Rosenthal fibers, which they are, as you guys remember, I told you it's basically the pinkish lollipop for a kid. So here is a pinkish lollipop, here another pinkish lollipop, Rosenthal fibers, and here we can find Rosenthal fibers as well. تمام. طيب, now I want you guys to tell me what's A. Glioblastoma multiforme. Sania, you answered this. I want someone else to answer B. What's B? Like, give me that the name of the tumor itself. In B, we have a vascular, and we have perivascular, and it kind of looks like a rose or a flower, but it's around the vascular area. So it's perivascular pseudo rosette. It's ependymoma exactly. طيب, what's D? I think D خلاص we saw it multiple times. So D, it's basically the blue cells surrounding an area of what's known as a neuropil, forming a rosette. So this is which tumor? Medulloblastoma. Exactly. It's medulloblastoma. Um, any questions about CNS tumors? All good. تمام. I think alhamdulillah we're done. Do you guys have any questions in general or any concept in pathology that you don't understand and you want me to explain? Yeah, I just remembered one thing. In this slide, okay, so in this slide I put this. What's this? This is basically showing us what's known as Wallerian degeneration. It's basically something that's seen in it's a feature or an abnormality that's going to be seen in a type of injury. It's basically diffuse axonal injury. So diffuse axonal injury is a type of injury that happens whenever we have an injury to the axon itself, and it's most commonly happening in cases of trauma. So, for example, trauma, or or we can call it as acceleration deceleration injury. Please know these two things: acceleration deceleration injury. It's important for is the most common cause of diffuse axonal injury. I remember we had a question about this in our midterm, neuro midterm, and I didn't know what does acceleration deceleration mean, and I got the question wrong. So just know this. And because of the transection of the axon and the damage to the axon, there will be the formation of what's called as spheroids or spheroids. It's basically showing us here, this is basically a spheroid. It's characterized by enlargement of the cell body. So this is the cell body. It's basically enlarged and the nuclei are pushed towards the periphery. So this is basically this happens in diffuse axonal injury, which happens as a result of trauma or acceleration deceleration injuries. So I think, yeah, that was the only thing that was left. Other than this, I think we're good. Does anyone have any question, guys?